welcome. This microlearning session is going to be on ST elevation myocardial infarction. So some learning objectives for today. We're going to identify the hallmark signs and symptoms of STEMI. Demonstrate the appropriate nursing actions during a STEMI event. So what are we going to do for them as the nurse? Differentiate STEMI from other acute coronary syndromes, which we have a couple, such as NSTEMI or angina. Identify the nurse's role in post-STEMI care. So what are we going to do for the patient after they've had this massive heart attack? So what is a STEMI? STEMI, we already said what it stands for, ST elevation myocardial infarction, MI being a heart attack. It's a type of heart attack caused by a complete blockage of a coronary artery. It shows up on ECG, which I'm going to show you in the next slide, as ST segment elevation. And then some of the symptoms are some of those classical symptoms for heart attacks, right? Chest pain, shortness of breath, nausea, sweating. We know this is a medical emergency, and what we do for it many times is procedures like PCI. That's where they're going to go on your wrist or your groin and go and unblock that artery. So what do we see on the EKG? So here's a normal one. We got a beautiful PQRS segment, T wave. Here is a STEMI. So what happens is if we were to do our J point down here on our line, and this is our isoelectric line here, we have our ST segment, so QRS T segment, that gets elevated above the isoelectric line. And we're not going to get in the weeds in this course on how much millimeters and all those things. That can be something if you decide to go on to be a provider or advanced cardio nurse, you might go into that. But basics of this is that the ST segment elevates beyond the isoelectric line. And then our other EKG, and I'll step out of the picture so you can see this better, is our NSTEMI. And in our NSTEMI, meaning non-ST elevation, we may have some ST depression, which you see there. It's going below the isoelectric line. So coronary blood flow, just a little bit of a review, when we're looking at an EKG and when you're sitting at home, maybe pull this up as you're looking at your EKG to find all your heart rhythms, what you're doing. So our LAD, which is the anterior descending artery, which comes down the front of the heart, this is our widowmaker, represents V1 through V4. So when you're looking at your EKG, V1 through V4. Our circumflex represents 1 AVL, V5, and 6. So that right-hand side of the EKG, if you're looking at it, so it kind of goes diagonal to the right. Our right coronary coming through the bottom of the right side of the heart represents 2, 3 AVF, so that bottom left corner of it. And then our posterior descending is on the backhand side. So if we decide to do a EKG on the back of the patient to see those arteries better, we may see that posterior descending. And that's a very interesting one, and I like to highlight that one because a lot of people miss it. Whenever I have anterior ST depression, so say my ST segment right coming up, it gets depressed, I should always do a posterior EKG. Take those leads and put it on the back of the patient to see if they have a STEMI on that side of their body. And that is known as reciprocal. So we will see changes on the reciprocal side of the EKG. So some medications, this is a fun little acronym to know. MONA-C, they keep adding meds to this, but morphine's a big one. If they have pain, they need it. Oxygen, if needed. I like to highlight this. If they do not need oxygen, don't put it on them. It's bad for them. Nitroglycerin, we're going to caution that in right-sided preload dependent MIs. Why am I saying that? What does nitro do? It dilates. So if I'm having a right-sided heart attack, right, the right coronary artery is messed up. If I dilate this more, I limit even more preload going into my heart. So what I mean by that, if you had your heart up here, right, and you have blood flow coming up into your heart, if I dilate everything, I am going to lower the amount of preload going into my heart, thus causing me not to have a great contraction going into the next beat. So we're very cautious when they have a right-sided heart attack to give nitro. Aspirin, very common for everyone. Beta blockers after they have a heart attack to lower their heart rate and prevent remodeling. ACE inhibitors, many times given, these or ARBs to help with remodeling. Statins, high dose, So I get asked this a lot. Why are you giving me a cholesterol med? My cholesterol levels are normal. It doesn't matter if you've had a heart attack, right? We know that you have high cholesterol in your vessels, most likely, unless it's from like cocaine use or something else, you have high cholesterol. Heparin, very common given as a drip when they first are having the heart attack, and then Plavix is many times combined with our aspirin. These are together. Put those together. Aspirin and Plavix usually for at least 6 months together after their heart attack. So pathway to care. I kind of drew this out for you guys. So like what happens when our patient comes in and they're having a heart attack? That's a STEMI, meaning they show EKG changes, versus a non-STEMI and they're still having a heart attack. So a patient comes in with chest pain. Both of them are going to get immediately assessed. Both of them are going to get an EKG within 10 minutes. We do that, the nurses. Maybe even a tech paramedic too. ST elevation is present. Then they go with 2 large bore IVs, very similar to NSTEMI. It's just the NSTEMI has no ST elevation, but we still think they're having a heart attack, right? Their troponin could be positive. They could have high-risk symptoms, those type of things. Aspirin, nitro, if no right side, Plavix, heparin drip, fluids, all those things are going to get before they go to the cath lab. And then the same thing could happen with our NSTEMI, but they may go to the unit first or may have a delayed cath before they get cathed right away. So we activate the cath lab, even if it's at night, we wake them up, they come in, they'll put a stent hopefully in that patient. And then this one still may get a stent placed. It's just not going to be right away as quick, right? So they're still going to get admitted, perform echo, and then cath as indicated. So let's look at some questions here today. A client arrives at the emergency department with crushing chest pain, high-risk symptom, radiating to the left arm. We always think about that. That's not always they're present, but today it is. Nausea, diaphoresis. EKG shows ST elevation at 2-3 AVF. So what part of the heart are we thinking? So if you're thinking 2-3 AVF, that's that bottom left side. We are thinking the right side of the heart. Which of the following actions should the nurse take? Administer sublingual nitro, place the patient in high Fowler, notify the provider and prepare for immediate cardiac cath, start high flow oxygen at 10 liters. So let's look at this question from this perspective at the top. We know the patient has ST elevation at 2-3 AVF, right? So they have a right-sided heart attack. If we go back through our pathway of care, they have ST elevation. This is what we're going to be looking at, additional interventions, with our goal getting them to the cath lab, right? What did we learn about nitro earlier with our right-sided heart attack? We learned that this is probably not a good option, right? Because it's going to dilate them more, reduce their preload. High Fowler's position, why would be my question, right? We don't need to put them in high Fowler's position. And then what in the question would ever need oxygen? We don't, right? It's not something the patient needs. A lot of times we want to put oxygen on a patient, but if they have a good saturation, we don't need to do that. So what are we going to do? We're going to notify the provider and then prepare the patient for the cath lab. One more. A client diagnosed with STEMI is receiving care in the ED. The nurse notes new onset shortness of breath, crackles in the lungs, and oxygen saturation of 89. Not good, right? What do we want to see that? Greater than 94%. What action, so this question is asking us to do something, what action should the nurse take first? So what is one thing we could do and walk away? What is the number one thing we should do? Administer morphine to reduce preload, okay. Give furosemide IV as ordered, all right. Apply oxygen to raise the head of bed, and then administer aspirin to prevent clot progression. So these are all good options, right? All those are good, plausible options. What action are we going to take first? And this is one of those ABC questions. So airway, there's not an option here. Breathing, the only option we have here is giving them oxygen. Because C would do this. Morphine's part of C, circulation, furosemide, and aspirin is all part of those meds portion getting down into C. So our correct answer here would be apply oxygen and raise the head of bed to hopefully get this oxygen saturation up. So some key takeaways today. Early treatment is critical. Remember, we want these guys in the cath lab as quick as possible. Hopefully getting them under 60 minutes would be ideal. Know the symptoms. Do an EKG, find ST segment elevation. We want these EKGs less than 10 minutes. Most patients are going to get aspirin. With that aspirin, many times they're going to get Plavix or clopidogrel. Nitro, caution, and right side. Is there any other time you should use caution when you guys are sent at home or every hour today? What is another time we should use caution with nitro? Hopefully you're thinking if the patient takes medications like Viagra, Cialis, those can cause massive hypotension. So the patient may get blood thinners such as heparin, and then aftercare matters. Once they get out of the cath lab, we got to make sure we keep their heart healthy. The highest risk to have a re-heart attack is within those few first months. So get in their meds, make sure we're having lifestyle changes, get them into rehab, those type of things. Hey, so thank you so much, guys, for joining me today for a micro learning on STEMI.